Good morning, everyone, and welcome to our annual finance update for GP practices. It's lovely to see so many people have joined us again this year, and welcome to all of those who are joining us for the first time. My name's Kay, and I'm Head of Healthcare here at Duncan & Topless. We've got a dedicated specialist team to support our practices, ranging from services to act as a virtual finance manager, bookkeeping services, accounts, tax, pensions to multi-million-pound property deals and allowance claims, as well as VAT, PCN and Federation business services. Today I'm going to be running through the contract changes for 2024-25 before moving on to my usual hot topics section. Damon Tunnicliffe, our Head of Payroll, who also specialises in and leads our NHS payroll and pensions team, will then be giving a payroll update. Can I please ask that if you have any questions as we go through the session, can you note these in the chat section, please, and I'll respond to them at the end. There will also be a feedback form sent to you shortly after the event, so if you do prefer, please pop any questions in there. So last week, myself and some of the healthcare management team attended the AISMA, so that's Association of Independent Specialist Medical Accountants, conference. And so I have brought into my presentation some thoughts and comments and updates that we gleaned that I hope will be useful for you all. The conference speakers were all either GPs or professionals specialising in healthcare. And we heard the BMA, solicitors, people specialising in annual allowance and lifetime allowance support, PCSE and a surveyor, to name but a few. It's really important for us to understand not only your accounts, but areas that we can support you to look at to improve profitability as we head into what we know will be a really challenging year for you financially as things stand. In 2004, the new contract was brought in with a clause enabling the government to impose changes with 12 weeks consultation, but this was only to be enacted in times of national emergency. This is the fifth time the contract has been imposed in the last 20 years. First in 2008, when Gordon Brown imposed a contract forcing extended hours, no national emergency. In 2013, when Jeremy Hunt imposed a contract which led to funding cuts and target chasing. Further impositions in 2016, 2022 for enhanced access again, 2023, and this year they have imposed the contract for the third year in a row. In 2020, there was a national emergency, but they didn't impose the contract, and that was obviously because the GPs were desperately needed. My husband often sarcastically says, work harder and faster and achieve more from less. He's also employed by the government. Sadly, that really seems to be what GP practices are being asked to do. Now, I could spend this webinar talking through all of the negatives, and yes, we will be covering things that are negative for your practice, but my outlook when life throws things at me is if something happens or is thrown at you that you can't undo, you can't turn back time, promise not to start to sing, there's no point in getting upset, angry, or constantly going over it. It's happened. Let's put our energy into how we're going to deal with it, how we can turn it around or make the best of it that we possibly can. In the meantime, whilst you're working hard on this, we know that the BMA have advised NHS England that they're entering a dispute with them over the 2024-25 GMS contract in England, and that industrial action could be on the horizon. So members will be getting involved behind the scenes as they want to. This webinar is going to look at the changes as they currently stand, possible issues, and where to look to improve matters. Practices have what they have for now, so they need to stay as positive as possible and focused on how to best make this work. The contract has not been accepted, as I've said, it has been imposed, and the key areas of concern are around patient care and recruitment and retention of staff. The well below inflation increase to baseline contract funding is going to be far from the uplift practices need to recruit and retain staff to enable them to provide sufficient patient access and ultimately quality of care. We know that there is concern that it could lead to practices serving notice on contracts as well. So how do we get through this year, keeping our good team members, looking after them, looking after our patients, and making sure the partners also see a rise in profits, because ultimately any deficits come out of their pocket. We have seen over the last year lots of practices giving their staff pay rises, but the partners certainly not seeing anything like the same level of pay rise themselves. Ultimately, a pay cut in a time of high inflation. So how do you make this work? I wish I had a magic wand. I make no apology for the next slide. I was watching the good old Matthew Corbett's Sooty show the other night with my little boy, and when putting my notes together for today and saying magic wand, this is the picture that sprung to mind. I do confess to a much loved Sooty puppet, but sadly no working magic wand. But hopefully throughout this presentation, you can pick up some tips, hints and key things to go away with and look at that can help you to maximise profitability, which ultimately will give everyone, team, partners and patients, a better 2024-25. Because obviously the more that we can make practices work, this benefits everybody, as I say, the team, the partners and the patients. So let's have a look at the main contract changes first. So once again, NHS England's letter explains the changes as looking for simplification and freeing up practice time and improving patient access. The contract baseline uplift. There will be an overall increase in investment of 215 million in 2024-25, and this is intended to support a 2% uplift in pay for contract GPs, 64 million, salaried GPs and other practice staff, 91 million, and also ARS staff. A further uplift may be made following the government's response to the Doctors and Dentists Pay Review Body, the DDRB, for 2024-25. And the DDRB report is currently scheduled for May 2024. Global sum is increased to reflect a 1.68% inflation, in line with the government's November 2023 GDP deflator forecast for 2024-25. And just a quick mention here that the fact this inflation level is in line with GDP is a bone of contention, because unlike CPI, which measures price changes in goods and services that we purchase, GDP measures these purchased by us, the consumers, and also business, government, etc., and it's a lower percentage. Also, it's supposed to include 0.38%, that's 35 million, for the Office of National Statistics population growth. So what does it mean for your practice? The global sum payment per patient will be £107.57 for 2024-25, and you'll recall that last year's figure started at £102.28 per weighted patient list size, and then that was uplifted to £104.73 later in the year, following the highly advertised uplift for salaries. And this caused practices a huge problem, because it was splashed across the press that practices were being given 6% within the 23-24 contract in total for uplifts to salaries. And this was widely viewed as all staff should be given a 6% pay rise because practices had the funding for it. But it absolutely was not the case. The contract is broken down into three elements: GP contractor income, staffing expenses and other expenses. And the staff element represents only 44% of the standard contract amount. So the 6% that they were giving in total that year, 2.1% at the beginning of the year and the further 3.9% backdated later in the year, was based on a 6% increase to 44% of the standard contract sum, which is based on weighted patient numbers. And so it doesn't reflect the actual wages cost to the practice at all. This did impact GP practices differently and left them having to explain to the staff that the advertised 6% they received was not based on actual staffing costs, but in most cases a much lower figure, and it also needed to cover on costs, so employers' pension and national insurance. Something I was urging practices to do was to be open and honest with the teams about these figures, not necessarily disclosing what the actual figures were, but explaining the difference between what a lot of staff thought they were going to get to what they were actually getting, and reassuring them that the practices were passing on what they had received. So all in all, a £2.84 uplift in the GMS core contract sum per weighted patient. The out-of-hours adjustment is to remain at 4.75% for GMS practices, and for PMS practices, this will equate to £5.11. There's also adjustments for not providing minor surgery of the 0.6% of global sum. The network participation payment will remain at £1.76, a little bit of rounding, per weighted patient, the same as last year. We've then got QOF, so NHS England will suspend and income protect 32 indicators out of the 76 QOF indicators, and align a couple of the indicators referring to the cholesterol control as well. The value of a QOF point for 24-25 is £220.62, up from £213.43. However, the national average list size has also increased to 9,964 compared to 9,639 last year. So a little bit crafty as always, because if you do the maths, based on pounds increase and average list size increase, it equates to no more money. So any increase will be around the list size increases, points achieved, and increases around the APDF, so that's the adjusted practice disease factor. And the adjusted practice disease factor is your practice disease prevalence divided by the national average disease prevalence for a particular chronic disease. So it's very important for maximising your QOF money. You need to be recording. Income protected indicators are worth 212 points. NHS England has income protected an increased number of indicators for this year, building upon the income protection of the disease register indicators within QOF for 2023-24. A further 13 indicators will be subject to this income protection. QOF bringing, for 2024-25 QOF, bringing the total to 32. So this includes 19 register indicators, 6 clinical indicators, 1 public health indicator and 6 quality improvement indicators. And these 32 indicators, as I say, has a total of 212 points assigned to them, which is a third of the total points available within QOF. The indicators that are income protected, practices will have their 24-25 achievement in points set at the same level as that achieved in 23-24. But it should be noted that this means practices will not be penalised for falling performance within the income protected indicators, but they also won't be rewarded for improvements in those indicators. Income protection doesn't mean that the payment amount will be the same in 24-25 as in 23-24, because the QOF earnings will continue to be subject to those prevalence adjustments, list size variations, with these being based on the 24-25 figures. Therefore, the final payment amount may be different. Practices will continue to be expected to maintain the registers and accurately code patient records with up-to-date information on the diagnoses, because doing this is really important for maintaining clinical quality. There will continue to be a GPES extract of the diagnosis, which is used to calculate the prevalence adjustments for indicators. If you don't maintain the registers, it will have an impact on prevalence adjustments and therefore will impact on practice income at the end of the financial year. So then within the QOF, you've got your personalised care adjustments. So there was exception reporting, and now it's the personalised care adjustment, PCA. And this allows practices to differentiate between a few different reasons for adjusting care and removing a patient from the calculation. As with exception reporting, applying a PCA to the patient record will remove that patient from an indicator denominator if the QOF-defined intervention has not been delivered. It will not result in the patients being removed from the disease register or other target population, and this mechanism differs from exclusions. So there are strict do's and don'ts around what and how to apply these, so you have to be really careful, but ultimately these also impact on your income, so make sure you have gone through the information thoroughly and don't miss anything. Finally, aspiration payments have been increased to 80% from 70%, and that's to assist your monthly cash flow. But you just need to remember there, if you're preparing budgets and cash flow forecasts, that obviously the reward payment will therefore be lower if your 24-25 total achievement is likely to be similar to the 23-24 overall achievement. So move on now to vaccinations and immunisations. So NHS England are going to expand the shingles cohort as part of the 10-year expansion of the programme in line with the JCVI advice. The expansion of the competent cohort is proposed for the implementation over 2 5-year stages, and the first years have been confirmed. So the first 5-year stage, Shingrix, will be offered to those turning 70 and those turning 65 years of age in each of the 5 years as they become eligible. The second 5-year stage, subject to confirmation of funding, the Shingrix will be offered to those turning 65 and those turning 60 years of age in each of the 5 years as they become eligible. NHS England will also change the current Vaccine standards, including shared data on vaccination status of patients with local child health information services and any other system nationally required, and support the Child Health Information Services data cleansing. It's to improve data quality for vaccination events, so rationalisation of SNOMED codes used for vaccinations to improve that data quality. Improved data recording of vaccination status, including new patients registered having arrived from overseas and where there is unknown or incomplete history to offer vaccinations in line with the UK schedule and Green Book. Practices must amend data they are informed is incorrect to ensure accurate and up-to-date patient vaccination records. NHS England will continue the weight management enhanced services for 2024-25 with an unchanged item of service payment of £11.50 per referral, and there's a cap on the total funding of 7.2 million for that. In respect of armed forces veterans, NHS England will require practices to have due regard for the needs and circumstances of armed forces veterans when offering services and making referrals. There are updates regarding digital telephony. So from October 2024, the GP contract relating to digital telephony will be amended to require practices to provide data on 8 different metrics through a national data extraction. And the 8 metrics are call volumes, calls abandoned, call times to answer, missed call volumes, wait time before call abandoned, callbacks requested, callbacks made, and average call length. And that data will be used by ICBs and NHS England to support service improvement and planning, and will be available for PCN use. The PCN will use it to gain better insight into patient demand and access trends, which systems can use to support understanding of operational pressure in general practice, and gain better understanding of patterns of demand and periods of surge activity to inform commissioning of local services. There are changes to the performance list regulations. So PCNs and GP practices will be allowed to agree with ICBs the deployment of any doctor that is employed or registered with bodies designated by the medical profession responsible officers, Regulations 2010, Schedule Part 1 only, to deliver primary care services without being on the medical performers list. There will be a corresponding change to the GP contract regulations. So these changes will permit GP practices and PCNs to employ doctors who are already employed, for example, by an NHS trust or NHS Foundation trust, without the requirement for the doctor to also be registered on the medical performers list. And the supporting guidance will also be issued to clarify that non-GP doctors should not see undifferentiated patients and that they continue to be required to operate within their sphere of competence. By October 2024, practices will be contractually required to adopt and offer both formats of the new registration solution that NHS England has co-developed with patients and practices to make registering with a GP easier, simpler and standardised. In respect of continuity of care, the provisions in the GP contract regulations will be amended to explicitly require continuity of care to be considered when determining the appropriate response when a patient contacts their practice. Workforce data, practices and PCNs will be required to submit workforce information on a quarterly basis to the National Workforce Reporting Service. So moving on to PCNs now. NHS England will streamline 8 of their clinical specifications into a single higher trust spec. So the 8 specs were medicines optimisation, enhanced health in care homes, early cancer diagnosis, social prescribing service, CVD prevention and diagnosis, tackling neighbourhood inequalities, anticipatory care and personalised care. And that's going to be going into one single overarching specification with a greater outcomes focus. The only separate service spec will be enhanced access. They're also simplifying the role requirements for PCN clinical directors, focusing on requirements for delivery of modern general practice and allocation of resources and accountability to the ICB. So there'll be a more flexible funding pool for the PCNs because they're going to be rolling the clinical director and PCN leadership and management money into core PCN funding. So PCN funding, the enhanced access payment has gone up from £7.58 to just over £7.67. That's multiplied by the PCN's adjusted population at the 1st of January 2024. Core PCN funding is £2.91, just over £2.91 per patient, £2.22 almost of that being multiplied by the PCN registered list size at the 1st of January, and the remainder multiplied by PCN adjusted population at the 1st of January. And that combines the funding that was previously labelled as core PCN funding, clinical director payments and PCN leadership and management payments. And the total of those in 22-23 was just over £2.91. Capacity and access support payments are £3.24, just over £3.24, and this was previously £2.76. The local capacity and access payment is in addition to the capacity and access support payment, and it requires activity around modern general practice access, including digital telephony, simpler online requests, and faster care navigation, assessment and response. The PCN clinical director must therefore, by the end of March 2025, assess all practices against the improvements, and if all practices across the PCN have met the improvements, a payment of just over £1.39, up from £1.18, will be paid, and that represents a third of the amount. The PCN's additional roles reimbursement sum equates to just over £22.89 this year, compared to £22.67 last year. And finally, the care home premium remains at £120 per bed. Let's go back to my previous slide. So if we go back to the investment and impact fund, so that's the PCN's equivalent of QOF basically. So NHS England have said that they're streamlining that and redirecting the funding to the capacity and access payments that we've just looked at. And funds amounting to 292 million for 24-25. The IIF will be reduced from 5 indicators to 2, worth 13 million, with only the indicators on learning disability and fit testing retained. Changes to Rs as well, so NHS England will now include in the Rs scheme enhanced practice nurses in the roles eligible for reimbursement. But what is an enhanced practice nurse? It's not currently a job role recorded by practices or PCNs for workforce data collection. They're a level above the registered nurses and below advanced and consultant level practice nurses. And there are specific guidelines, though, as the enhanced practice nurse must hold an appropriate nursing degree, be registered with the NMC, have a postgrad qualification at level 7 or above relevant to their area of enhanced practice. And as a new role, it's capped at 1 per PCN, unless your PCN has over 100,000 patients, in which case you can have 2. The PCN have also removed the cap on its direct patient care roles. So PCNs will be able to recruit other direct patient care, non-nurse and non-doctor MDT roles if agreed with their ICB. Where PCNs already have 1 mental health practitioner in place, 50-50 funded by the PCN and the mental health provider, funding arrangements for subsequent MHP roles will be for agreement between the PCN and the mental health provider, subject to ICB approval again. They're also allowing reimbursement for training time for personalised care roles, undertaking training or apprenticeships. But as I'm sure you're aware, NHS England have said that they will claw back any unspent Rs money with no commitment to keep that in general practice. And the other issue, of course, is that the R's funding increase is again less than inflation and still can't be used for GPs or practice nurses, which practices are desperate for help with often. All right, just move my slides on. So there's a list of the R's roles. So a key focus has been modern general practice access again. So we've spoken about some of these as we've gone through already. So just a very quick run through. NHS England are making the following changes. So that's the 70% payments of the capacity and access support money into the PCNs monthly with no reporting requirements. The 30% capacity and access improvement payments, which are payable on PCN confirmation that they have put in place all components of the modern general practice access model. Digital telephony that I mentioned earlier at practice level. Online patient registration process, as well as paper registration that we've mentioned. Digital copy of practice boundary using NHS England's mapping tools, and strengthen the reference to continuity of care as a criteria when considering response to patients initially contacting the practice. Not on the slides, but a few things BMA want looking at. Certain income streams that have not been uplifted, such as the sickness and parental leave locum reimbursement, which has remained unchanged since 1920. Vax and IMS, amendment of the personalised care adjustment in respect of childhood vaccinations due to the impact that that has on funding, as well as an uplift to the item of service fees. They want guaranteed annual investment uplifts to cover annual DDRB pay reviews. These practice employed staff pay uplifts to be guaranteed. So those were the main contract changes as they stand, and practices do need to be fully aware of those contract changes and the impact they will have on funding and workload. It's also essential now more than ever that practices look carefully at their current and future strategies, particularly with regard to time and resources. Collaboration across primary care networks is key, as well as internally, obviously, within the practice. The highest proportion of practices' income is contract income, generally over half of a practice's income, the rest being made up of QOF, enhanced service income, other NHS income, other non-NHS income, rent reimbursements or notional rent. So what do you need to be doing? Well, firstly, for anyone not already doing so, you need to be looking at preparing budgets or forecasting cash flow. You really need to be, or you need to be asking your accountant to help you. It's essential for the practice cash flow that you're monitoring these so that you can react in plenty of time if there are likely to be any pinch points. Some partners in practices are having to review their drawings level. And in some practices, not many, but in some, we do see a lack of understanding that any shortfall does have to be covered out of the pockets of the partners. So preparing budgets and forecasts also helps you to keep on top of cash flow issues, such as numerous problems that we see with salaried GP pensions, for example, and we'll come back to that later. So I've just got a list on the screen on this slide about some things that you can do aside from preparing your budgets and forecasts. So just put there team education. You need to make sure that you're communicating with your team. They need to be aware of their impact on the finances. And this can be from right person, right job, signposting, a full awareness of financial implications of whatever role they play. So for example, clinical team that performing services that you claim for, are they aware of what they should be coding and the financial implications if they miss anything? We've already talked about QOF and the importance of the prevalence and personalised care adjustments. You need to make sure that everybody is aware of the correct up-to-date codes needed, especially where you have temporary staff and templates aren't automatically updating. Ensure claims are submitted as required. Are the finance team aware of what's being claimed to enable them to ensure the money comes in and is correct? Remember, there are deadlines on back claims now for a number of income streams. So where we've picked it up in accounts after the year end, there are times where that's just too late for claiming that money back and it hasn't been honoured. So you do need to be keeping a track of that. I've done some training sessions with practice staff before, and it's amazing how many haven't been aware of the financial implications of their actions in respect of coding. And make sure you code everything too if you're a coder. We'll cover some more income in a minute. Patient education. So, for example, flus, be open and honest. Nobody wants to think that their local surgery is at risk of closure. So tell them that you really need them to come to you. Flu should be a really good source of income if dealt with efficiently. And again, we'll come back to this later. Communicate information to your patients that may help them understand things. For example, why they don't always need to see a doctor, what they can do to help you be more efficient so that you can remain viable and they don't lose their local surgery. Be open and honest. Are you charging for everything you can in respect of private fees? And if so, is it an appropriate level? When was the last time you reviewed them? When you have your notional rent review, get it checked. Don't let your GPs automatically sign and agree it. There's potentially more income there. Are you providing any services that you're not getting paid for? If so, why? Is there a good business reason? If not, could this work be replaced with work that you can get funding for? Meeting clinical targets and QOF targets. Impact of relying on protections when you then move back to performance and activity. So just because it's protected, as we've said earlier, it doesn't mean don't record. And we did see a lot of practices caught out when income protections were removed after COVID. Effective use of resources. Ensuring all your team is fully utilised. If not, what income could they be generating? Can you cover a number of patient issues in one visit and create any efficiencies? Purchasing effectively. So this isn't necessarily looking for the cheapest, this is looking for what is the best value, and consider where you cut costs and the knock-on impact. Don't cut costs in areas that can add value or add profitability or protect you, or anything that could be causing you an issue further down the line. And I think a classic example would be not to cut costs on partnership agreements. Get them done and get them done properly. They may need to stand up in court one day. Hopefully not, but it does occasionally happen. Other issues, cutting costs on accountants and using ones who have no experience in NHS pensions, leaving partners with incorrect pensions and causing huge cash flow problems. In our experience, this is of taking on practices who have previously been with non-specialists who just haven't understood NHS pensions, and it has resulted in large costs and incorrect pensions. Effective communication with patients. So what is the quickest and cheapest option, but ensuring it's in line with patient abilities? So that's looking at texts, phone calls, or letters. So then just to move on to a few reminders around drug profits. And this is for dispensing and non-dispensing practices. So make sure with your personally administered items that everything used is recorded so it can be claimed, that everyone is aware of what can and can't be claimed. So a perfect example would be the sutures. Certain sizes are claimable and certain ones aren't. So you need to be making sure that you're buying and using the ones that you can claim and recording the correct ones. Make sure the team know on the larger items at least what the refund rate is each month, and ensure that they're buying at a rate which will make profit. Don't forget to take into account any discounts both on the income and the expenditure when you're looking at that, and also VAT. Morenas, you actually only pay 5% VAT on, and the PPA refund 20, or PCSE refund 20%. If you won't make a profit on a certain drug, is there an alternative that you could do? Don't forget to spread scripts out across GPs so you don't lose out on the dispensing fees with it being a sliding scale. And be savvy with your dispensing fees, which are based on items dispensed. In respect to flus, don't order late and get charged extra. And remember that sale and return is limited now, so don't over order, otherwise you'll be trying to sell on the excess flus to try and get some money back. Don't over order any other stock that may risk going out of date and having to be disposed of. There may be items that you just can't make profit on, so consider writing a script for those. I appreciate that will depend on where the nearest pharmacy is and the impact on the patients, but it's a consideration. Ensure scripts are correctly completed so you don't lose money on your script fees. And actually consider outsourcing the checking of drugs income, because it currently passes through so many hands in a practice and PCSE that for as little as £60 per month plus VAT, you could get somebody else to be doing those checks for you. It could be done by a specialist team with the necessary IT links that are just every month on it, what is happening. Yes, it's an extra cost, but is it going to find you more income and save internal costs of some of that work, which can be quite time consuming, especially keeping on top of all the changes, the monthly changes. Of course, the other issue here is that the dispensing fees have been moving, and sometimes quite significantly within a financial year. So just moving on to costs, and your biggest cost is obviously your staffing cost, including locums. And Damon will be running through a payroll update. But as you will know, the national living wage has just gone up by 10% from £10.42 to £11.44 per hour. And that has impacted practices massively. And you're having to deal with a knock-on effect, obviously, across other staffing salary levels as well. The meagre uplift to the contract did not cover the necessary uplifts due to this, and the need to try and retain good staff. You need to be looking at contracts, particularly around overtime rates and sickness policies, in respect of how that will impact on your finances. But also consider job roles and duties. Can you cross-skill your staff? Can you cross-skill them more than you have already? That could assist with holiday and sickness cover, for example. Plan your holidays and cover well in advance to aid the cost of cover. The sooner you can get the team to agree holiday dates, the more likely you are to be able to ensure you have sufficient cover in the existing team as much as possible without incurring too many additional costs. And I appreciate that depends on which roles you're looking at for holiday cover. But the more time to plan, the more cost effective the cover will be normally. Use your R's roles. So in 2019, we saw the introduction of the primary care networks, and GP practices were really pushed to join or risk losing funding. And these were to group practices together to achieve the benefits of working at scale, looking at more efficient working by working together across practices with community services and to reduce healthcare inequalities. And it was aimed to give the ability to hire additional team and manage escalating workloads. Funding has been focused more and more towards the PCNs rather than your individual GP practices. So you really need to make sure you are aware of what is going on in your PCN and what you can be doing to maximise your income share or access to staff. Also be aware of what's happening in your federation too, if you're one of the practices listening who are part of an active federation. And with PCNs and federations, you need to be talking to them, work with them, make sure you're getting the best out of them. I know there are some fantastic ones out there that really support their practices, but equally we have seen some pretty shocking ones. Have you had a business cost consultant in recently? They don't cost anything, but they can save you a lot. The one that we used as a business has been out to various practices over the years and supported cost reductions with some fairly simple wins at times and no reduction in quality of what is being purchased, but some really good savings. One thing I haven't discussed in this webinar are area specifics around how enhanced services are paid locally, because there are various people on today from various areas and so are seeing different methods of payment. So you need to ensure that you are aware of the changes and how they impact on your practice as well. Watch and make sure you are not effectively being diddled or facing issues through those. So next, a few hot topics. So really quite long topics on their own. So I'm just going to flag these to enable you to raise any questions or that might come out of them. And some of them, it'll be a case of there'll be more information coming. So basis period reform. So this only applies to non-March year ends who are partnerships. And hopefully your accountants have been talking to you about a change of year end to March 2024, which we've obviously just passed. You don't have to change the year end, but if you don't change your year end, it means that you'll be paying your accountant extra fees, as they'll have to calculate all partners' personal tax on a 5th of April basis, which means using proportions from 2 sets of accounts every year. So all of our clients are moving to March year ends, and it sits nicely with the NHS year end. HMRC allow 5 days grace, the 5th of April, so they accept the 31st of March as being the tax year for that purpose. By changing your year end this year to 31st of March 24 and not further down the line, the partners will benefit from being able to spread any overlap tax, hopefully a familiar term to non-March year end practices listening, over 5 years or over the period to them leaving or retiring if that's earlier. So it just gives a little bit of relief on cash flow. The McLeod judgment, so the deadline for the remedial service statements is the 6th of October this year. So those are the statements that show what a partner's position would have been if they'd remained in the old scheme. By April 2025, the total reward statement should show both the rollback, so the old scheme, and 2015 scheme options. And there's going to be a lot of work required around this, as annual allowance tax contributions and tax relief on those all need considering. There are various scenarios where compensation has been agreed for professional fees in respect to the calculations that will be needed. For some it's capped and for some it isn't, so there is compensation out there. Notional rent reviews, I did actually mention earlier, that was just a reminder to practices not just to sign off the notional rent review. It really is worth getting a second opinion. We often see surveyors finding practices more money. PCSE. So we had PCSE at ASMA conference last week, and they gave us an update on a few things. So you'll be pleased to hear that they are looking at streamlining the process of the performers list update and joiners and leaver forms into a single document. They're also looking to improve access for accountants so that we can edit rejected forms rather than have to get partners to change the status before we can. So hopefully another good thing there. NHS sickness claims. I just wanted to remind practices that they can claim where GP partners are covering. You just need to send in an invoice and it can go through the practice as an extra session, and the accountants can adjust for it in your annual accounts. Just make sure that you are getting all you can, especially as those costs have been increasing, but reimbursements haven't. And finally, for my section, a few reminders. So PCSE and superannuation issues. So joiners and leavers, there is detailed guidance on the PCSE website of processes required. The leaver process is straightforward and can be actioned by the practice. The joiner process relies on various steps, from the GP joiner updating the performers list, or being able to, because we have had some frustrated GPs who haven't been able to update the performers list or get hold of anybody at PCSE who can help. So we are aware there are a lot of problems still with PCSE. Then the practice needs to confirm and complete the joiner form. Another issue we've seen with joiners is with the SD number, so that's the pension number. And the pension number will be on any NHS pension correspondence, total reward statements, or you can phone NHS pensions to find that out. Estimate of superannuable profit forms, so don't forget to update these throughout the year, or let your accountant know of any changes so that they can be updated. And that's for changes in salary for salaried GPs, as well as joiners, leavers, people opting in or out, and any changes to partnership profit shares as well. PCN profits obviously need including in practice accounts. Remember that that's for the unincorporated PCN. There are obviously out there a lot of PCNs who have got a limited company sitting to the side to manage staffing and various income streams and profits, but there should somewhere be sitting the PCN as you working collaboratively with hopefully a little bit of profit in there. New pension tiers and pay rises, so that's just a reminder to be mindful of pension tiers for staff and salaried GPs when giving pay rises. So not quite such the jump in tiers that we have seen over the past few years between tiers, but just £1 into the next tier gives them no more pension, but they've had to pay the higher rate on all of their income. That also is a reminder to watch if, for example, a salaried GP does an extra session, to just watch how close they are to the next tier. GP earnings declaration. So this is the website one. So the ridiculous and meaningless figure, but it still has to be calculated and put on your website. That continues. We were hoping that would disappear, but unfortunately, it looks like it's still here. We've heard nothing about them giving up with that one. Declaring GP earnings over 159,000 for 22-23. That threshold for 23-24 is 163,000. And if anyone is declaring it, of course, it is supposed to be contractual, but I believe that there have been mixed responses to whether people have declared or not. The calculations are based on superannuable profits, and so for anyone who isn't in the scheme but have earnings around that level, then the same calculations have to be done as they do for preparing the superannuation certificates. I'll pop seniority on there. I did send an email out to all of our clients about this, advising that they dispute and request breakdowns of these seniority adjustments that they're being asked to pay, generally pay. A few of them have come out at £1 or £2, so probably not to worry about those, but we have seen some substantial amounts as well. And there've been a mixture of issues. Some calculations have been correct, but some calculations have absolutely not been correct, and that there've been issues with what figures have been picked up. Or a classic example of one where PCSE had approved a certificate that they had uploaded onto PCSE Online because it was before PCSE Online existed, so a manual one had been submitted, and they'd approved it but with no figures in, and were then trying to claw back around £6,000 from one GP. Partnership agreements, so another reminder, and I know I mentioned partnership agreements earlier, but just a reminder of how important these are. Please do make sure that they are up to date and they are accurate, and use a medical specialist solicitor who knows all about particularly properties and the way the NHS works, notional rent, etc. Not on the slides, but I did also want to just very quickly mention recruitment and retention schemes. So the future of recruitment and retention schemes is being reviewed, so more information to follow when that comes out. It can be a helpful source of income or GP support, as can the use of trainees if you have the right support in the practice. So thank you for listening, and I'm going to pass you over to Damon whilst I'll check the chat screen for any questions and then come back to you at the end. So over to you, Damon. Thank you.
So good morning, everybody. And I'm going to be talking this morning about a pension and NHS pension and payroll update. I'm going to start off with pensions, because that probably is now the hotter topic at the moment. We're through April's payroll, and I know a lot of our focus here at Duncan Topplest then now turns to NHS pensions and making sure that we're submitting the SD55s before the deadline of the 31st of May. So NHS pensions have confirmed at the completion of the annual SD55 year end submissions that there is no requirement to include mid-year contribution rate changes. So when you're submitting, if you do submit your SD55, it is just the contribution rate at the end of the year. So basically what the employee was contributing in March 2024 as their tier. So if you administer them, you know how much time that saves, rather than having to put mid-year contribution rate changes throughout. Employer contributions, they are actually increasing as well, but it's not impacting on the employer or organisation. So if your cost as an employer organisation remains at 14.38%, however, the central payments made up by NHS England has increased to 9.4%, so overall meaning an increase of 3.1%. So total now is 23.78%, up from 20.68%, which obviously includes that 0.08% admin charge, so a little bit extra coming from NHS England. The employee contributions, the second phase has now been confirmed, which came live from April. As you can see, that has been condensed down from 11 tiers to 6 tiers. Therefore, less changes for those employees who were mainly between the 6.1% and the 9.8%. The assessments have to be done each month as based on actual pensionable pay from the month before. If there weren't pay rises in April, then employees' tiers were based on the actual pensionable pay from the year before. Please note that is extra work that is now having to be done, as if you do process your own payroll, if we process your payroll, it's not something that we can help. We have to do it, and it's a change made by NHS Pensions. So that's what's come into force. Other changes from the 1st of April 2024. Overtime is pensionable, as it has always been, for part-time workers, except where a member has recently taken partial retirement. Pay, as you know, is normally pensionable up to the full-time equivalent pay. But in the previous 12 months, though, if an employee has taken partial retirement, then any overtime additional hours won't be pensionable. So if we process your pensions, then we'll be able to keep a track of that. But if we don't, then something to track, you will need to tell us whether that's overtime is pensionable or non-pensionable. If they have taken partial retirement, we can put a note on the file. So payroll changes, as Kay has alluded to earlier, that these are changing, and a lot when it gets to minimum wage are spiraling quite considerably now. So the pay-as-you-earn thresholds, rates and codes remain at 12,570 for personal allowance, with the 40% band starting still from £37,701. So in reality, that means there's £50,271 before you're at the 40% taxpayer or your employees. But in reality, that salary really equates to £56,000 as pension, as you know, reduces taxable pay down. At this time of the year, we always get queries on P60s. That's with the employees' salaries or salary GPs, because they are looking at the employment figure, but it is not the employee's gross salary, it is the salary after tax with the pensionable pay deducted. So NI thresholds remains the same for employees and employers. So that is at the employee and primary threshold remains at 12,570 or £1,048 per month with a bit of rounding. Changes from April is that national insurance is now calculated at 8%. That was changed in January to 10%, but that now has been further reduced from April of 8%. So employees that are receiving pay slips on pay today or this month would see a slight reduction in national insurance to increase net pay slightly. Looking at the costs, employer and secretary threshold remains at 9,100 or roughly £758 per month. So you as a practice or organisation will pay 13.8% on any income or any salary after the £758, sorry. So just something to think about when budgeting or hiring is those extra costs that affect practices. National minimum wage, as Kay alluded to earlier, you know, this has been quite staggering this year, and looking at the percentage gaps, and it's going to be increasingly difficult now with certain income being cut to practices. More importantly, is to provide certain reports to keep on top of your budgets. Please let us know if we process your payroll, if anything we can do to assist with making sure you're keeping track of your budget, but also likewise if you're processing your own payroll, it's good to run those year-to-date reports to keep a track of. So on the screen there is really the new rates that are coming in effect from that came in effect from April this year, and I just want to draw you to one of the main changes this year, and that you'll see is that the top band is now age 21 and over. That used to be 23 and over. So for those employees that were currently last year on £10.42, they're now increasing £1.02 to £11.48, which is a 9.8% increase. But for those who were aged 21 and 22 that moved to 11.44 as well, they actually receive a 12.4% increase, or the £1.26 uplift. 18 to 20 year olds increases to £8.60 from £7.49, which is a 14.8% pay rise, or £1.11. And 16 to 17 year olds is a 21.2% increase to £6.40 from £5.28. The ones that you might have a staggering jump of is your apprentices that have now completed their first year and above 19. So we've seen some apprentices rise from £5.28 up either to £8.60 or £11.44. So there is some real big difference in changes there. All the statutory rates, so your maternity, paternity, adoption, shared parental and bereavement pay, are increasing to £184.03 per week, up from £172.48. And SSP has been increased to £116.75 per week, up from £109.40 per week. So looking at that, a 5-day worker now on SSP, because that's prorated depending on how many days per week you work, is £23.35 per day, up from £21.88. One of the big changes to affect the statutory payments this time is paternity pay. So there is new legislation that permits fathers or partners to split their leave into 2 blocks of 1 week, as long as they're taking their leave and pay at any point in the first year of birth, rather than in that first 8 weeks and consecutive. So quite a large change for fathers or partners there. Student loan and postgraduate loan. So student loan plan type 1 has increased. That has increased, so anybody with a plan type student 1, that has increased from a threshold of £1,834.58 per month to £2,082.50. So really getting more in line with plan type 2, which was frozen at £2,274.58 per month. If people have student loans and they aren't hitting those 2 thresholds, then they don't get deducted the 9% for student loan. And just to finish with postgraduate loan, that has also been frozen at 6% with a threshold of £1,750 per month. So I am conscious of time, so I'll hand back to Kay. I'm sure both of us now will happy to field any questions that you may have.
Thank you very much, Damon. Okay, we have got 1 or 2 questions. So will the caps be increasing on the Rs rolls by 2% in line with the suggested staff pay increase? So yes, 29 million, which is a 2% increase, was added to the Rs budget because they are expecting those Rs rolls to be increased by 2% in line with the rest of the NHS staffing. We've also got a question around, do we offer a service to help with superannuation reconciliations and claiming back from PCSE? Yes, we do support our clients and we can support with that. One issue that I didn't mention earlier that we do see is with there can be some quite large balances outstanding for earlier years in respect of salaried GPs. And as I'm sure many of you will remember, in the good old days, not that long ago, there was a form that had to be completed by the GP practice that had the salaried GP's salaries on them and tier levels, and the salaried GP was also preparing a form, and everything seemed to run quite nice and smoothly. Now there's nothing that the practice can do or give. You're relying on what PCSE have got in their system and relying on the type 2, the salaried GPs completing their type 2 certificate. So often those balances are sitting there and have been sitting there for a long time because those salaried GPs aren't completing their type 2 superannuation certificates. So some encouragement is needed for them to prepare those so that it can sort out any issues in respect of those balances. There are, of course, other problems as to why, the salaried GP may well have submitted certificates, and we all know with partners in the practice that certificates can have been submitted and then PCSE can tell you they haven't had them, and we've had so many examples of that. Some where they have processed the balance, so you know that they've had it, they couldn't have processed the correct balance otherwise. Some where they haven't, some where they've processed them a couple of times and taken from a practice the balance twice. So there are a lot of issues, but yes, we can help with the reconciliations. I think we got to the point where you have to take a little bit of a view. So if we can see a salaried GP has completed their certificates and it has been agreed and approved by PCSE and there's some smaller balances, then I think it's just a case of, it's probably not cost effective to continue. Let's just write it off. So yeah, so it's taking a bit of a view, looking at the cost effectiveness of what you're dealing with, and there can be various reasons and various things that are causing problems. I'm just hopeful that now PCSE are talking about this one form for the joiners, because I know there's people on this call that there's been some terrible problems with getting PCSE to take amounts, and I just only talking to a practice earlier, well, last week, huge amounts that are sitting in their bank account that belong to PCSE for salaried GP superannuation, which of course distorts your cash flow. It's all very nice, but it's not going to be very nice when it all gets taken. And yes, okay, that's a practice where they looked at cash flow and everything, and yes, it is okay when they take it, but you shouldn't have to be dealing with that and chasing them to sort it out. And in that case, there's one poor salaried GP who was desperately trying to get the performance list changed. That was the one I referred to earlier in my talk, and they just don't make it very easy, do they? So hopefully with a new form, some of these problems will disappear. But in the meantime, definitely talking to your salaried GPs, making sure they are completing certificates. Obviously, there are going to be practices where there are balances that do need sorting out, and the salaried GP has quite possibly moved on. You might not even have contact details for them. So then that's really liaising with PCSE and seeing if PCSE have got those contact details to chase them to try and get them to complete those forms. But then I've just said leaving it in PCSE hands again. So so those there are a couple of queries there. There was another query around our payroll services. It's not come up with who asked that question, but if that person can just email Damon or myself directly, then we can help you with that one. There's also a question, Damon, around have we got any advisors that could visit practices to talk to staff about NHS pension?
Yeah, and that's something that we're starting to do more of. We've done it for a couple of practices, and we've got a couple more booked in. So please do let me know, because we could tailor the session to this a little bit sometimes of different requirements of what practices want around that. So yeah, please know that. We're also doing a pension online session on Thursday morning, with it being start of May, just to make sure everyone's happy with submitting pensions, their SC55s on pensions online. So please do let us know if you've not had that invite. I'm sure Jasmine and the team can get that sent out to you. And I think I've just got another question here. So veteran and I question, can we back claim this if we missed it? Yes, you can. So from 2022, you can do that through your payroll software. Depending on what payroll software you would use, you'd have to roll back the employee change national insurance category, resubmit the FPS adjustment, resubmit the year end as well, because that year end submission always needs to be the last submission. So happy to talk through that in more detail. If it's before April 2022, then that's by a letter to HMRC, so probably will take you a lot longer to get that money back from HMRC, but effectively the real-time one through the payroll should be quicker, because that should update, and then you should reduce your liability next payment to them. So yeah.
Super, thank you, Damon. And as Damon mentioned, I think as any of you doing your own payroll will know, there is a huge amount of work now around the NHS pensions, particularly in the changes over the last year or two with the tiers and the thresholds. So it has increased the amount of work involved, hasn't it? And I know we've had a few people call us and ask to assist with the various threshold changes and the mid-year tier changes. It's they don't like to make it easy, do they? Has anybody got any more questions? There's no more up in the Q&A screen. As I said, if you want to email directly or pop on your feedback forms afterwards, then we're happy to help get back to you individually. So please do feel free to ask, and please do fill in the feedback forms that come out, and if you've got any suggestions for future topics or anything that we've briefly covered today but you'd like something a little bit more detailed, then do let us know. We like to tailor our webinars and try and make them useful to what everybody wants to hear. Okay, so I can see we have actually overrun by 10 minutes. I'm sorry, my slot was quite long, wasn't it, in the end? But thank you very much for joining us. It's lovely, as I say, to see so many of you joining us again today. So enjoy the rest of your day, and thank you very much.